Greetings, Professor and Doctor. My name is Fadhli and my research title is Monovision versus Multifocal Intraocular Lens Implantation in Cataract Patients, a systematic review and meta-analysis. Cataract was the top cause of blindness worldwide, with prevalence of 1.2% on a global scale. Higher incidence was found in low-middle countries due to lack of diagnosis and treatment, and the cases will be rising as the elderly population grows. It is burdening, and we need affordable and effective cataract surgery, particularly in developing nations. Loss of accommodation after cataract surgery is challenging. One of the complaints of patients is that they still need glasses after surgery. Different methods exist to correct this condition, including premium intraocular lenses like multifocal lenses and pseudophakic monovision techniques achieved through monofocal IOL implantation. Multifocal IOLs can make patients less dependent on glasses, provide good results for both near and distant vision, but the price is high and some side effects were reported. Monovision is a technique where one eye is corrected for distant vision, while the other is corrected for near vision. It is affordable using monofocal lens and covered by Indonesia Health Coverage Insurance, also an accessible option for improving near vision as well as distance. Recent studies showed no differences in visual acuity and spectacle independence between multifocal IOLs and monovision. However, for spectacle independence and other side effects, many studies remain contentious. We conducted a systematic review and meta-analysis to compare the visual outcomes of patients who received multifocal IOLs to those who received monovision after cataract surgery, with the main outcome to compare spectacle independence, visual acuity, contrast sensitivity, and presence of glare. This study was performed by 3 investigators. Literature search was done on 6 databases. Terms used were cataract surgery, multifocal, and monovision. Studies published until April 7, 2023 in English and available in full text were included. The risk of bias of ROB2 for RCT and Robbins eye tools for non-RCT or observational studies were used. Total of 237 studies were found, and after removing duplicates and screening of the studies, 10 studies were included in analysis, with 2 RCT and 8 observational studies. Both RCT have low risk of bias, while half of non-RCT studies have shown some concerns of bias in various domains, particularly in bias in measurement of outcomes. No indication of high risk of bias was found. All studies have indication for bilateral cataract surgery over the age of 40 years. Monovision was achieved by targeting different power between minus 0.5 to minus 2 dioptry in non-dominant eyes. Various brand of lenses were used in monovision and multifocal groups, including diffractive or refractive or combination in multifocal IOL. For spectacle independence, from 502 patients showed a higher use of glasses in monovision compared to multifocal group with relative risk of 0.53, p-value less than 0.05. This showed that multifocal group is less dependent on spectacle in daily activities. For binocular visual acuity, both groups' uncorrected distance and near visual acuity showed no difference. This means monovision was comparable in terms of visual acuity as stated from most studies. For contrast sensitivity, a total of 322 patients' contrast sensitivity were tested through failure of some tests and showed no difference between 2 groups. Some previous research indicates that monofocal IOLs typically provide superior contrast sensitivity in diffractive multifocal IOLs, while in refractive multifocal IOLs showed no difference. And the last is presence of glare, with a total of nearly 400 patients showing a lower number for the monovision group with a relative risk of 2, p-value less than 0.05. This means multifocal IOLs have more symptoms of glare than monovision, like the findings from other studies. Although this study is a systematic review that includes all studies covering the same topic, there are some limitations. First, differences in the target power of the non-dominant eye in the monovision group can affect the patient's comfort level, with higher power being more difficult to tolerate. Then different types of multifocal IOLs, such as diffractive or refractive, and the last is difference in studies quality between RCT and non-RCT. Despite the various shortcomings, This systematic review and meta-analysis can provide a new picture of how monovision compares to multifocal IOL on important aspects to consider for patients undergoing bilateral cataract surgery. In conclusion, monovision could achieve excellent outcomes as the multifocal group in terms of visual acuity and contrast sensitivity in patients with cataract surgery. In addition, monovision also exhibit less presence of glare while being affordable. However, multifocal IOL had a significantly higher percentage of spectacle independence. These are our references, and thank you.